When most people turn on the television for information about COVID-19, they are met with brief headlines, simplified charts, or political debates framed to fit neatly into short time slots. What rarely comes across in those tightly packaged broadcasts is the raw and unfiltered reality experienced by those who work directly with patients day after day. Imagine a nurse standing in a crowded ICU, hearing the beeping of monitors, watching oxygen levels fall, and coordinating with physicians in real time to decide whether a patient needs intubation. That lived experience contains layers of scientific, medical, and emotional knowledge that can never be condensed into a 30-second news clip. The Frontline is where theory meets practice, where medical journals collide with human suffering, and where science is constantly being tested against unpredictable variables. Yet the voices from this arena are often drowned out or heavily edited to match a particular media narrative. This disconnect creates a situation where the public sees only fragments of the story, rather than the complexity that health professionals navigate every single day. Consider how media outlets often present the pandemic in numbers, new cases, death counts, vaccination rates, without digging into the nuances behind those statistics. On the front line, every number represents a story, a patient's pre-existing condition, the speed of viral progression, the trial of different medications, and the toll on families waiting anxiously for updates. A physician may notice that two patients of similar age and background respond very differently to the same treatment, sparking questions about genetics, immune response, or underlying health disparities. These real-world puzzles drive the evolution of medical understanding, but they rarely make it onto prime-time television, which is more focused on broad narratives than on the gritty, shifting details. The Frontline perspective exposes the limits of one-size-fits-all explanations and reminds us that science is not static. It evolves with each observation, each failure, and each small success. Television also tends to simplify science into black and white categories, safe or unsafe, effective or ineffective, right or wrong. But ask any clinician working with COVID-19 patients, and they will tell you that almost nothing is that clear-cut. Treatments that seem promising in one patient may fail in another. Preventive measures that appear straightforward in theory may be far harder to implement in crowded living conditions. Health professionals on the ground are forced to balance conflicting data, adjust protocols on the fly, and remain open to changing their approach as new evidence emerges. Their insights capture the true scientific process, which is messy, iterative, and full of uncertainty. A reality that rarely translates well onto a TV segment designed to reassure or alarm viewers in simple terms. Another important aspect hidden from most screens is the human dimension of scientific discovery. The constant trial and error process is not just an intellectual exercise. It plays out on the bodies and lives of real people. Frontline workers carry the emotional weight of losing patients despite every intervention. The frustration of misinformation undermining their work, and the exhaustion of endless shifts. These human experiences generate insights that cannot be found in lab data alone. The recognition of subtle early warning signs, the importance of patient communication, and the practical barriers that patients face in following medical guidance. Such details shape how science is applied in reality, and yet, because they are harder to fit into a polished broadcast, they are often left out entirely. The gap between what the media presents and what the Frontline reveals is not simply a matter of omission. It influences how the public perceives risk, compliance, and trust in institutions. When the Frontline perspective is absent, people are left with a filtered version of the truth that may feel disconnected from their personal experiences. By unmasking this difference, we see how vital it is to listen to those directly engaged in the fight against COVID-19, because their perspective embodies the living science that television sound bites cannot capture. When you step inside a hospital ward during the height of the pandemic, you quickly realize that the story of COVID-19 is far more complex than the charts and statistics presented on news broadcasts. Every patient carries a unique case study, and frontline doctors and nurses become detectives, piecing together patterns that textbooks and television summaries cannot fully explain. Imagine watching a patient in their 30s with no prior health conditions suddenly deteriorate within hours, while another patient, older and with multiple chronic illnesses, stabilizes against all odds. These contrasting scenarios raise urgent questions that only emerge in real-time practice. Clinical observations gathered at the bedside form the raw data that later drive scientific studies, yet these crucial insights are rarely visible to the public. Instead of hearing about the subtle shifts in how the virus manifests from patient to patient, audiences are often fed broad, uniform narratives that fail to capture the unpredictable nature of the disease. Frontline workers notice trends that cannot always be quantified in neat datasets. They see the strange clustering of symptoms, some patients presenting primarily with severe respiratory distress, others with blood clotting issues, and still others with neurological complications like brain fog or loss of smell. A nurse, after caring for dozens of patients, may recognize a faint but recurring patter, a particular type of cough that tends to precede a rapid drop in oxygen saturation. A physician may observe that patients who arrive earlier in the course of illness often respond better to treatments, while those who wait too long to seek care face steeper uphill battles. These details rarely reach the television screen, yet they hold the keys to improving early detection, adjusting interventions, and saving lives. Clinical observations are not abstract concepts. They are the real, world manifestations of how science plays out in the unpredictable theater of human biology. What makes these frontline insights especially compelling is how they challenge assumptions. For example, while media outlets may broadly categorize risk by age or pre-existing conditions, clinicians see exceptions every day. A teenager with no known vulnerabilities may develop severe complications, while a patient in their 70s recovers faster than expected. Such experiences force medical professionals to question established narratives and search for deeper explanations. Perhaps genetic variations, differences in immune response, or environmental factors that alter outcomes. These observations, born from direct contact with patients, drive the curiosity that leads to research breakthroughs, yet they remain largely hidden from public view when filtered through mainstream coverage. There is also the matter of treatments and how patients respond in practice. A drug that shows promise in clinical trials may behave differently in a diverse, real-world population. Frontline physicians are the first to notice these discrepancies. Which combinations of medications reduce the need for ventilation, which supportive care strategies improve comfort, and which interventions prove less effective than anticipated. In the high pressure environment of the ICU, every observation matters. Sometimes the smallest detail, like how quickly a patient regains appetite or whether they can tolerate lying in a prone position, offers clues about recovery trajectories. These on-the-ground findings accumulate into a body of practical knowledge that shapes protocols long before formal studies confirm them. Even beyond physiology and treatment, frontline observations extend to social and behavioral dimensions. Health workers see how misinformation influences patient behavior, such as delays in seeking help or reluctance to follow medical guidance. They witness the disparities in outcomes tied to socioeconomic status, access to care, and cultural barriers. A doctor may notice that patients from certain communities consistently arrive later in the course of illness, not because of negligence, but because of systemic obstacles. These lived realities add depth to the scientific story of COVID-19. showing that the virus does not act in isolation but interacts with human environments and inequalities. By pulling back the curtain on what happens at the bedside, the Frontline perspective offers a dimension of truth that charts and TV discussions cannot replicate. It is in the quiet notations on a patient chart, the hurried conversations in hospital corridors, and the instincts sharpened by experience that science reveals itself most vividly, providing insights that reshape our understanding of the pandemic as it unfolds in real time. When discussions about COVID-19 reached living rooms through television, much of the focus circled around mask mandates and basic reminders about hand washing. But what was rarely explored in depth was the actual science of how the virus moves from person to person and what Frontline experiences revealed about its transmission. Imagine sitting in a hospital ward where entire families were admitted one after another, not because of a single casual encounter, but because of prolonged indoor exposure in poorly ventilated spaces. For Frontline doctors and nurses, the spread of the virus was not an abstract chart or a political talking point. It was a tangible chain of infections traced back to living conditions, air circulation, and behavior patterns. They witnessed firsthand that this pathogen was not just about droplets falling within a short distance, as was initially explained on TV. Instead, it lingered in the air, thriving in closed environments where people gathered without proper airflow. These Frontline observations painted a far more detailed picture of transmission than what the public typically heard in short televised segments. Masks became one of the most debated topics, often reduced to a binary argument about whether they work or don't work. But on the ground, health professionals saw their protective power play out daily. A nurse wearing a properly fitted N95 could tend to multiple infected patients and walk away without contracting the virus, while a simple cloth mask offered noticeably less defense in high-exposure settings. The difference in outcomes was stark, and it wasn't theory, it was lived evidence. Frontline staff could quickly distinguish between environments where masks made infections plummet and those where improper or inconsistent use left people vulnerable. This contrast revealed that masks were never just about the material, but about fit, consistency, and context. Yet the nuanced layers, why a well-sealed respirator matters in a crowded ward or why ventilation paired with masking drastically cuts risk, were rarely broken down in detail for the public watching TV. Another revelation from the Frontline involved understanding super-spreader scenarios. Clinicians noticed that a single infected individual in a choir practice, a wedding, or a restaurant could trigger dozens of cases in one night. The common denominator was not always physical closeness, but rather prolonged indoor exposure combined with poor ventilation and the absence of masks. These situations reinforced that transmission was heavily influenced by air circulation and duration of contact, not merely by whether two people happened to stand 6 feet apart. While television anchors repeated the 6-foot guideline as a blanket rule, Frontline experiences demonstrated that distance alone could fail when aerosols accumulated in the air. This practical knowledge pushed many health workers to advocate for improved airflow systems, open windows, and portable filters, interventions that rarely received the same spotlight in mainstream discussions as masks or vaccines. Frontline workers also witnessed the psychological barriers surrounding mask use. They saw patients who delayed care because they doubted the usefulness of masks, only to end up severely ill. They noticed entire communities adopting masks consistently and experiencing slower spread compared to areas where masking became a symbol of resistance. These patterns underscored that the science of transmission was not just biological but also behavioral, shaped by trust, misinformation, and cultural dynamics. In hospitals, the lesson was clear. Adherence to both masks and ventilation measures created safer environments for staff and patients alike, while inconsistency left cracks through which the virus spread relentlessly. Every day at the bedside, These realities unfolded in ways that could not be captured in simplified TV soundbites. The Frontline perspective showed that transmission was a dynamic interplay of air, surfaces, masks, and human decisions, each factor amplifying or reducing the likelihood of spread. What was most striking was how much of this knowledge came not from theoretical models, but from the lived evidence of those who spent hours inside the same rooms where invisible particles decided the fate of patients and their families. When the topic of COVID-19 treatments and vaccines appeared on television, the messaging was often simplified to sweeping declarations. A new drug was either hailed as a breakthrough or dismissed as ineffective. A vaccine was portrayed as either a miracle shield or a source of fear. Yet on the front line, reality unfolded in shades of gray, far from the black and white portrayals designed for prime-time segments. Imagine a physician juggling multiple patients, each with different health histories, reactions, and outcomes, while simultaneously reviewing the latest medical journals and hospital protocols. What frontline workers saw was a constant evolution: treatments that seemed promising at one stage, vaccines showing varied responses across demographics, and the need to adapt rapidly as new evidence surfaced. These complexities rarely made their way to the general public in full, even though they held the key to understanding what was truly happening inside hospitals. The story of therapeutics provides a striking example. Early in the pandemic, drugs like hydroxychloroquine and remdesivir dominated headlines, sparking debates that often leaned more political than scientific. On TV, viewers heard definitive takes, "this works" or "this doesn't," but in hospitals, doctors observed the actual effects in real time. Some patients seemed to stabilize with certain medications, while others showed no improvement or even worsened. Health workers had to weigh side effects against potential benefits, all while the world outside expected clear answers. Corticosteroids, for instance, became a game changer for severe cases, but that discovery came only after countless frontline observations and global collaboration. The reality was messy, iterative, and filled with trial and error, far removed from the streamlined version that reached living rooms. Vaccines, too, carried a similar duality. Television narratives often painted them as absolute, either the silver bullet to end the pandemic or a target of skepticism fueled by misinformation. But from the frontline perspective, vaccines were powerful tools with nuances that mattered. A nurse could tell you how vaccinated patients generally experienced milder symptoms, recovered faster, and required fewer ICU admissions. But they could also point to breakthrough infections and the challenges posed by emerging variants. Physicians noted differences in response between younger and older patients, between those with strong immune systems and those who were immunocompromised. These realities highlighted that vaccines dramatically shifted the odds in favor of survival, yet they were not impenetrable barriers. Such subtleties were critical for informed decision-making, but they often disappeared in the rush to produce sound bites for broadcast audiences. Another key dimension was the timeline of interventions. Frontline doctors consistently observed that timing mattered. Ministering certain treatments early could alter the course of illness, while delayed care often reduced their effectiveness. Vaccination campaigns followed a similar logic. The earlier people received protection, the greater the collective benefit. These time-sensitive observations underscored that science was not just about what worked, but when and how it worked best. This level of detail rarely reached viewers, who were left instead with broad statements stripped of the contextual richness that could help them understand why outcomes varied so widely. Even beyond biology, frontline workers recognized that access played a pivotal role in shaping outcomes. In wealthier hospitals, patients had quicker access to antivirals, advanced respiratory support, and vaccination, while under-resourced settings struggled with shortages that forced providers to ration care. Television rarely conveyed this disparity, leaving the impression of uniform access when in reality, inequality heavily influenced who survived and who didn't. Nurses and doctors saw first and how social determinants of health, income, geography, and systemic inequities interacted with science to create vastly different realities for patients. For frontline professionals, every patient was a lesson, every intervention an experiment in progress, and every vaccine dose a glimpse into a shifting future. These daily encounters revealed that COVID-19 was not a battle won by a single pill or shot, but by a layered, evolving strategy built on real-world evidence, context, and adaptability that rarely fit into the neat narratives broadcast on television screens. When the conversation about COVID-19 policies reached the public through television, it often came across as a series of political arguments, official announcements, or brief safety reminders. What rarely surfaced in detail were the voices of those on the front line who understood not only the science, but also the lived consequences of policies in action. Imagine a doctor finishing a 12-hour shift, walking out of an ICU where patients struggled for breath, and then turning on the TV to see debates reduced to talking points about mandates or restrictions. The gap between what was being said and what was being lived was wide, and frontline professionals recognized that trust, transparency, and actionable guidance were just as important as ventilators and medications. Policies could not remain abstract. They had to make sense to everyday people navigating work, families, and fears. Frontline workers understood that communication had to go beyond statistics. They watched how patients and families responded when given clear explanations compared to when they were left in confusion. A nurse explaining why mask use mattered inside a crowded apartment complex could make a bigger difference than a distant official reading numbers on TV. Doctors noticed that when information was framed with empathy and clarity, patients were more willing to follow guidance, take precautions, and seek care earlier. Conversely, vague or contradictory messaging created hesitation, mistrust, and delays in treatment. These observations revealed that effective policy wasn't only about rules. It was about human connection, and that was something mainstream broadcasts often overlooked. The question of trust became central. On the ground, health professionals saw patients who doubted official guidelines because they felt leaders were withholding information or changing narratives without explanation. Television often presented updates without context, leaving the public wondering why recommendations shifted so frequently. Yet to those in hospitals, the reason was clear. Science evolves as new evidence emerges. Clinicians had to adapt protocols constantly, sometimes weekly, as new data appeared, and they longed for that reality to be communicated honestly to the public. Without that transparency, shifts in advice looked like contradictions instead of progress, and trust began to erode. Practical, actionable advice also mattered more than abstract directives. On the front line, it became obvious that telling people to social distance was far less effective than explaining concrete steps. Open a window, wear a well-fitted mask, avoid prolonged indoor gatherings. These tangible practices, supported by direct evidence from clinical settings, empowered people in ways that broad policies often failed to do. Health workers knew that when advice connected directly to daily life, communities responded more effectively. Yet too often, TV coverage stopped at generalities, missing the chance to provide the public with strategies that actually reduced risk. Frontline professionals also witnessed how deeply social and economic realities shaped the impact of policies. They saw patients forced to choose between missing work to quarantine or putting food on the table. They noticed that communities with fewer resources had more difficulty accessing vaccines, tests, and treatments, which in turn shaped outcomes. For them, policy was not theoretical. It was personal, it was survival, and it had to account for inequality if it was to succeed. They understood that public health could not be separated from social realities, and they watched how policy decisions played out in real time on hospital beds and in emergency rooms. These experiences revealed that the frontline perspective held invaluable lessons for shaping communication and trust. Health professionals knew that honesty, empathy, and specificity were the tools that built compliance and resilience in communities. Without them, policies remained words on a screen, disconnected from the realities faced by the very people they were meant to protect.